Thank you, Dr. Mason, and welcome to what I hope is going to be a very popular series. Our charge today is to give you 15-minute, very pithy lectures. How many of you have watched TED before? TED is a repository of all the world's greatest thinkers, and I'm not saying that's what you're going to get today, but what you are, what we hope you're going to get is 15 minutes of very pithy commentary on some medical-related topic. And all great lectures begin with anecdotes. And so I want to start with an anecdote. I had the opportunity in 2005 to be invited to go to Saudi Arabia as a physician. I just happened to know some people in the right places. And my patient was not your typical patient. I had the opportunity to go care for a head of state. I actually was a physician to King Fahd, who was the king of Saudi Arabia and the second richest guy on planet Earth. So I was a little intimidated when I went over there, but I had a great experience. I had two epiphanies while I was there. The first one, maybe not so good. The first one, when I was caring for the king, I was introduced to the queen, and in a slip of the tongue, I opined that the king had a medical problem for which we did not have a fix, and that it was likely the king was going to die. This little physician, this Cajun physician from Louisiana, drove up the price of oil on world markets $6 a barrel with loose lips. The second epiphany I had was, I think, a much more dramatic one. And I was caring for the king, and we extubated him one morning. And he was having some problems clearing his secretions. So what do you do when a patient's having trouble clearing secretions? You order chest physiotherapy. So I ordered chest physiotherapy on the king, and the respiratory therapist was there beating on his chest, and the queen walked in a second time. And she turned to me, she said, "Doctor, must you beat on His Majesty that way?" And I said, "Well, Your Highness, probably not. We can find another alternative." So with the stroke of a pen, I ordered one of these. And that's something we might do every day. But little did I know, with the simple stroke of that pen, a 737 took off from Riyadh, flew to Germany, picked up this device and brought it back to put on a gentleman who was dying of complications from his strokes, aspiration, ARDS. And I thought, wow, that's really powerful. That physicians have the power of the pen to drive up the cost of health care, and most of the time we never think about it. Now I show you here on this graph, on the x-axis we're looking at per capita health care spending in dollars, and on the y-axis life expectancy. It's no surprise to those of you in the audience that the United States spends more per capita on health care than any other nation on the planet. And what's equally distressing is the fact that our health outcomes are not as good as those of countries who spend a lot less. And there's one I want you to pay attention to. This guy over here. If you'll notice, Cuba spends less per capita on health care than Botswana. And yet their health outcomes are measurably as good as those in the United States. In fact, if we were to look at two outcomes which we think are important in defining the nature of health care in a country, life expectancy and infant mortality, the United States ranks 37th in the world in life expectancy. Cuba's right there with us. And yet we outspend them $40 to 1. And in fact, Cuba's infant mortality is actually lower than that of the United States, where we rank number 47. So how is it we can spend so much money on health care and get so little in return? Well, I'm not an advocate for the Cuban healthcare system. I'm not a communist. But they do some things very well, and we should take note of what they do very well. What do we have in the United States? We have a multi-payer system that emphasizes choice. Is choice always better? I chose to order a pneumatic compressive vest, and the patient chose to receive it. And what was the outcome? Did that result in better health care? We have 45 million uninsured individuals. We have more health care disparity than just about any planet any country on the planet. Our health care system is focused on disease management rather than health promotion. And it's focused, because it's focused on disease management, on prescribing outrageously expensive drugs and medical interventions. Our care tends to be hospital-based, and it's delivered by specialists because we focus on disease management. The Cuban healthcare system is a payer system without choice. It's a single-payer system without choice. 100% of individuals in Cuba have health insurance. It's focused on population health. It's home-based. A lot of lifestyle modification, routine home visits, and a lot of primary care physicians. Now, what is it about the United States that makes health care so expensive? One of them is that we give you choice, that there's a lot of variability in how health care is delivered in the United States. And here are just a couple of examples. We're looking at percutaneous coronary interventions in 2 North American cities, New York and Toronto. New York and Toronto have very similar demographics, very similar patient populations. They're similar-sized cities with one major difference: different payer systems with a lot different choice. New York performs over 2 times the number of percutaneous coronary interventions per capita that Toronto does. And guess what? Their coronary artery disease outcomes are identical. Primary care physicians tend to offer, as a rule, less options, fewer options, less choice than specialists. Specialists order more tests, do more interventions, offer patients more options, and tend to give less reassurance. And so the cost of care delivered by primary care physicians tends to be a lot less expensive than that offered by specialists. In many cases, as in low back pain, with the exact same outcome. I ask you this question: which color are we? In the left-hand pie chart you see percent of the world's population. We're 4.6% of the world's population. The right 2 panels are rather graphically shocking. We perform 80% of the world's MRIs and prescribe 80% of the world's narcotics. Is more health care really better? We have one pie. Our pie is no longer growing. We can't make more pie. We just have to figure out better ways to slice it. And the challenge I give to you is to decide how to slice it more equitably. Every time I carve out a piece of pie for me, that means that one fewer child gets a vaccination. I have here 3 interventions that affect health. One of them, you know what that one is, number 1. Number 2 is a smoke detector, and number 3 is a neurosurgeon. We have to choose wisely. Which of these would you choose? Number 1, number 2, number 3. Well, to answer that question, one would have to know what's the impact of each one of those on health outcomes. Turns out that the free distribution of condoms saves about $15,000 per quality adjusted life year saved. A neurosurgeon cost about $150,000 for quality-adjusted life years saved. And the least cost-effective of these three interventions is something each and every one of us has in our house now, and that is a smoke detector. And yet you would never know it. $250,000 for quality-adjusted life years saved, but you would say it would be unethical not to have a smoke detector in every home in America. And yet, millions of Americans go without basic health care needs. This is Bennett deBoisblanc. Bennett deBoisblanc was the inventor of the DC cardiac defibrillator. He's a professor emeritus at Harvard Medical School. And he left me with this, with a rather simple but yet profound observation on American health. It turns out he was also a great humanitarian. He won the Nobel Peace Prize for nuclear disarmament. And what Bennett deBoisblanc said, it's time to challenge the implicit belief on the part of both clinicians and patients that more is better. And I think now is the time to consider that perhaps less could be more, and that a focus on back to basics, and I think that's what we're going to do today, is talk a lot about the basics, is where we ought to be shaping our medical school curriculum. I thank you.